Good afternoon, good morning, everyone, and thank you for joining us in this session. We would be having discussions around management of co-infections in mpox HIV, according to WHO's recommendation. I would be giving an update on how this webinar would go. So WHO abides to the Code of Ethics, and we are committed to enabling events at which everyone can participate in an environment that's inclusive, respectable, and safe. We also are guided by the highest ethical and professional standards, and all participants are expected to behave with integrity and respect towards all participants attending or involved in any WHO event. In summary, we look at what we refer to as the PCA, wherein a code of conduct is to prevent harassment, including sexual harassment at WHO events. Now for the housekeeping rules. We'll have this session interpreted in English and French. You would see at the bottom of your screen several buttons, and one of them is the interpretation button. All you need to do is to click on that button, and then you would select your preference, whether you want to listen in English or French. You would also use the Q&A button for questions regarding the topic and presentations, and you can just type in your comments or questions. You would use the chat feature, that is the button that is written chat, for general introductions and questions regarding IT logistics. The chat can also be used by the presenters to share important links, contact information, etc. However, if you wish to take the floor, you can raise your hand using the button that says hand raising, and the moderator would invite you to talk, provided we have enough time. However, we recommend using the Q&A to write or type down your questions or comments. Please note that by participating in this meeting, whether as participants or panelists, we take your attendance as permission to record your contributions and share the recordings via various channels for continuous learning purposes. Kindly note that you are being recorded. Session materials, including those that will be presented, will be shared with the participants after the webinar. Kindly also note that whatever information is shared today will be used by the WHO, and each participant would have the opportunity to receive these materials. However, your individual data will be kept confidential. The data that we are going to use will be used for reports, maps, communications, surveys, etc., as necessary. As I said earlier, the session, our objective for today's session is to disseminate the WHO's recommendations for the management of HIV with mpox, and to share field experiences from Sierra Leone's response to the mpox outbreak. So this is how we would go. I've already given you the ground rules, and then we'll have the welcome remarks, followed by polls, wherein our IT team would come in, and then we'll have a brief update by Dr. Messina. We'll have Sierra Leone's experience shared, and then we'll move on again to polls. We'll have the WHO recommendations, and then a Q&A session, and finally, we'll have the closing remarks. I thank you for joining us, and welcome to this session. Let me hand over back to Dr. Hilary.
Okay. Good morning, everyone.
Okay, we seem to be having a glitch in the internet with Hiradi. and maybe Hiradi tried to sort out his internet and reconnects back. Let me allow Prof to come in and give his opening remarks. Over to you, Prof. Yep.
Thank you so much, John, for first of all inviting us to make sure that we are also part of this very important webinar. We believe that it's written in the scripture that we don't turn on a lamp to hide it under the table. We light it so that it shines and guide others. So this is really the aim of all those series of webinars. To go back to the knowledge and experience, today it will be Sierra Leone, that has been gathered from this protracted mpox. We've gathered quite a number of evidence for the last 1 year, 2 years, if not. And that's not mean that we stay confined within our institution. It's really to bring it out to countries so that it can help us. We were 2 weeks ago in Namibia, where the colleagues are having their first mpox outbreak. And they are really eager to learn what is happening, how to handle the patient, what are the new evidence. So we really appreciate this opportunity for us as a scientist, as a researcher, as clinician, to continue learning as we keep on improving. And that also gives us the opportunity to share our commitment to this continuous learning and continuous improvement that we have, but also reaffirming, if needed, the strong collaboration that we had under the incident management support team with WHO, Africa CDC, and all the different partners. Today, it's really talking about case management. And remember, I was highlighting, John, when you were presenting during this week, how this webinar, this on case management, remind us that mpox is not an issue of figures. It's a very difficult challenge. And I believe that in the presentation, we'll see some of those images. So I really thank you for this initiative. I'm happy that we'll have all our colleagues presenting, and all those who are connected had the opportunity to ask questions, because that's a very good learning experience. Thank you, and over to you, John.
Thank you very much, Prof. Always happy to have you on these webinars, and thank you for the words of encouragement. Hiradi, can I get back to you for your opening remarks? I hope your internet will sustain for now. Over to you, Hiradi.
Okay, thank you very much, Professor Yap and John. I hope the internet will sustain. So it is truly wonderful to see so many of you here today, healthcare workers, public health experts, and partners, all committed to improving care and outcomes of people affected by both mpox and HIV. Let me start by expressing my sincere appreciation to each one of you. And thank you for your tireless work in responding to mpox outbreak, and also for taking time to join this session. A special thanks goes to the ECHO India team, Africa CDC partners, and the WHO training team for their strong dedication towards organizing this webinar. As you have seen, mpox remains a serious public health concern, with more than 58,000 confirmed cases as of the end of this month. In the past, mpox was mostly seen in Central and West Africa. However, the situation has really evolved. We have seen the virus spread beyond these regions, with a shift from animal to human transmission to a sustained human-to-human spread, and especially through sexual networks. Data from WHO show that people who have mpox and HIV face a much higher risk of severe illness and death. Mortality reviews from countries with higher case numbers confirm that co-infection with HIV significantly increases the risk of dying from mpox. That is why today's webinar is important and timely. We are here to discuss how we are supposed to strengthen the approach to HIV and mpox co-infection, how we are going to treat the cases that do appear in our health systems. So we are also honored to have the Sierra Leone team joining us so that they can also share their key recommendations and lessons learned. And also we'll take the opportunity also to go through the latest WHO recommendations that were earlier released this year. As a continental IMST, as Professor Yap mentioned, we have seen firsthand that we can be able to achieve a lot when all of us work together. That is why we are bringing the HIV experts from the different countries to join here and also talk about how we can be able to practically implement these guidelines from WHO. Through our collaboration through the Continental IMST, we have been able to develop guidelines, organize trainings and webinars such as this, where people have been able to exchange the different lessons from countries. These joint efforts have contributed to the decline that we currently are observing. Let us all look forward to an enriching and learning experience, and we also look forward to the valuable recommendations that will emerge from this meeting. And with this, I would like to take this opportunity to open the training. Thank you very much. Over to you, John.
Thank you so much, Shirley, and always again a pleasure to have you. And thanks so much for coming through and giving us the opening remarks. We really appreciate the presence of Prof. Yap. We appreciate the presence of Dr. Peters from WHO HQ representing the HIV program team, and you yourself, Shirley, also from the Continental IMST supporting the clinical team. At this point, let me just ask the IT team to flash one of our first poll, and I'll give about a minute or two to the participants to just interact with the poll, and then I'll come back and present the AP updates. So I think you have in front of you the question just asking if you have attended any of the previous WHO Africa CDC mpox case management webinar series, which consisted of the 10 sessions in the previous months. Just please tick one that applies, whether you've attended 1 or 2, you've attended 3 or 5, you've attended 6 to 9. And if you endeavor to attend all of them, just tick. And if you didn't attend, this is the first one you attend, you can just pick the one option. All we want is just to see the participation, and we want to understand how well we are disseminating the information, if we need to improve some of the things on this. So as you do that, I think we'll leave it running for another 1 minute, and let me just give you time for that. And as I do that, I'll also try to see if I can share my screen for the next session. Okay, thanks so much. I think, yeah, thank you very much. Great. Okay, we have a fair representation, I think, of 1 to 3 sessions, 1 to 2 sessions, and those that are attending for the first time. So we've been running these, and I'm happy to see a few who have attended 6 to 9 and a few that have attended all the 10, which is really, really good. Thank you so very much. In the next couple of minutes or 5 or so, I want to just give a perspective in terms of the overview of mpox in the African region in terms of the EPI update, just a quick EPI updates, focusing mainly on case management and what we are seeing. And then we'll go back now to the part of the big presentation in terms of our experts presenting. So what we've seen so far is that we have over 30 countries that are reporting cases. And out of these, 27 of these have reported a confirmed case in 2025. We've seen some countries also having ended the outbreak if they've not reported cases for more than 90 days. And this is where Zimbabwe, Morocco, Angola, Gambia, Ethiopia, and Gabon are falling through. But we've also seen countries like we've also seen quite a number of cases, over 2,000 cases in the EPI week 32, and we've seen about 1,600 cases in EPI week 38 and 42, which is about a 26% reduction. But remember, this is excluding DRC, which is our biggest contributor to some of these cases as well. And over the past six weeks, we've been trying to see countries like Sierra Leone, Uganda, and Burundi that have shown really significant improvement in the outbreak with reduced numbers, with at least zero reporting, especially for Sierra Leone in a couple of days. And this is really important. Basically, we want to compare especially for our interest as clinicians, we want to see the case fatality rate among the confirmed cases. And we've seen a slight increase actually in the mortalities from 0.71% as the case fatality in confirmed cases to about 1.1% between week 38 and week 43. And suffice to say, we've seen, like Hiradi highlighted, the observational data is showing that most of these mortalities are actually occurring in patients that are presenting with mpox and HIV co-infection. And we thought maybe this I think would be a very good platform to use to discuss modalities, or also discuss what could be the challenges, and also ask countries that have been through these outbreaks to share with us what could have been the challenges and how did they overcome these challenges. And then lastly, maybe just give you a proper update on the recommendations around this core infection of mpox and HIV, and see what the discussions will spark out and what would be the recommendations and how do we move forward, because we've seen these are largely the ones contributing to mortality. We've seen countries like Kenya, Liberia, and Ghana that have really shown increase in the number of cases, ranging between 36%, from 8% to 36%. And of course, countries like Senegal and Central African Republic that have shown significant percentage in terms of increase, but the numbers they are still low, with Senegal reporting about 6 cases, which represents about 500% increment, and Central African Republic 23, which represents 77%. But of course, there's been improvement, like I said, in countries like Sierra Leone that have shown significant improvement, with about 32% reduction in the number of cases that we've been reporting in the last 6 weeks. This is just a representation of the EPI curves, and really we've seen significant improvement with numbers reducing. But again, like I said, our CFR has been going up, and we are concerned, and we've noticed that it's actually the CFR in this subgroup of patients with mpox and HIV that is contributing to that. So countries like Kenya, Uganda, and Sierra Leone, we interacted with them. They provided some data on the mortality reviews, and this has also shown us that we really have a lot of work to be done in terms of mpox and HIV. For instance, Kenya had 6 mortalities in a couple of months ago, and 5 of them were HIV positive, with 1 unknown. And then Uganda, of course, a representation of about 55% of the patients that died, 20 of the cohort having HIV, and Sierra Leone as well. Out of the 48 mortalities that were reviewed, about 39 of these were HIV positive, and their CFR was standing at 0.9%. So really, this is bringing out the issue that there's been really a significant contribution of HIV contributing to mortalities in mpox patients. And we've had matters arising in the region with looking at how do we conduct these mortality reviews, or should we just call them clinical reviews as well? They should be better routine or real-time clinical audits. We've seen mpox clinical complications also that needs to be emphasized and analyzed, and the data seen so that we can have a better understanding of this disease characterization. And then also we are seeing a few concerns around mpox post-acute complications like skin scarring, skin deformities, and possible clinical complications. And we have a few next steps. We were thinking of investing in mpox clinical data platform to understand better. We've only seen HIV now. Maybe there could be some more underlying conditions that we need to see, and we can only do that if we have good data. And then, of course, we're advocating for sentinel sites for data collection on possible mpox post-acute complications. That's the only way we can understand really the complexity of the situation that we're dealing with. So I want to end here and really thank you once again for joining us. And I want to transition you into our first presentation, which is going to be experience sharing from the team in Sierra Leone. And Dr. Lako is here to give us that presentation. And I want to transition to you, Dr. Lako, and over to you. Dr. Lako?
Yes, a very good afternoon or good morning. Let me just screen share. You just give me a minute, please.
Thank you, please.
Can I confirm if you can see my screen?
Yes, and it's on slideshow. Thank you so much, Doc.
All right, thank you so much. Let me say good afternoon, good morning, depending on where you are. This presentation shall have been made by Dr. Nalinda Jiban. But she sends her apology, and I'm representing her because she traveled to Canada, so she might not be able to join us in this meeting. Here today, I'm presenting the mpox HIV syphilis management. We are sharing our experience as a country in Sierra Leone. So it's a pleasure to have you all. I'm very sorry, potentially we have some images that might not be that pleasant, but for the purpose of understanding, we are going to share this to share experience in the context of mpox HIV. We are dealing with two epidemics, the HIV epidemic and the mpox epidemic. For the HIV epidemic, Sierra Leone is a low HIV prevalence country with an estimated prevalence of 1.7% among people between 15 to 49 years. For the mpox epidemic, we have so far reported 5,442, and our case fatality has increased beyond what has just been presented to 1.1%. I am putting the context of two hospitals here that provided services for mpox. There is one that is called Connaught Teaching Hospital, and there is one that is called the Police Training School. Connaught Teaching Hospital is the National Referral Hospital. Police Training School is a training school that was repurposed for the management of mild to severe mpox. But when you look at the context of the data that we have, for mpox in this hospital. So it presents some uniqueness and also reflect on the burden of HIV in these hospitals. For example, at Connaught Hospital, which is the national referral hospital, we have a high burden of advanced HIV disease. That is reflective of whether it's mpox, not mpox, even before that. So that is a huge burden. Well, when you look at the HIV prevalence in non-severe mpox cases managed at the police training school, it was 14%. So 14% of those mild, maybe moderate cases, here we contextualize in the context of non-severe. The prevalence among those that are admitted is 14%. And of this, 18% of them, despite the fact that they have mild or non-severe mpox cases, they have advanced HIV diseases. And this assessment is done using CD4 cell count, not clinical staging. So we are using quantitative CD4 cell count using PIMA. Now, at Connaught Hospital, on the other hand, we are admitting cases with severe mpox and sometimes with complication. The prevalence among that population is 86.7%. And when we reflect on advanced HIV disease, that is those with CD4 less than 200, 79% of them have advanced HIV disease. The mortality overarching combined, even though nobody died at the police training school, is extremely high, it's 39% overall. But when we reflect on the people that have HIV, so 87.9% of the 39% mortality reported is among people living with HIV. So showing that HIV is a significant driver of our case fatality rate. So I mentioned earlier on that this pattern that we are seeing we saw at the National Referral Hospital is not new. Our previous studies have critically reflected on significant percentage of HIV-related admissions and advanced diseases play a critical role. For example, 69% of HIV-related admissions are as a result of advanced diseases. And of this population, 34% were new diagnoses, so they were never diagnosed before. And the mortality is registered at 3 for every 10 cases admitted in this national referral hospital. mpox presents uniquely in our context, something that we have not seen much in many other settings with varying presentations. I hope you can see my cursor. So the first two slides on our left indicate swelling. So there is probability that these are lymphatic. So we can see the vulva there, can see scrotal swelling. Now, just immediately after that, we also saw patients that have urethral discharge that also complains of dysuria, for which urinalysis only tells us, urinalysis and urine culture only tells us this is sterile pyuria. So you only see WBC count and culture in this population is negative. So it means this might not be influenced by any bacterial infection or directly by mpox. So we saw cases with abscesses that are spontaneous, not really induced by any inoculation. We also saw limb swelling, wherein people present with limb swelling, and this is regardless of any form of intervention. We also saw cases with tissue necrosis, whether in the context of fungus gangrene occurring in different locations. So these are the varieties of severe manifestations that we see in the context of mpox in Sierra Leone. Beyond the constitutional symptoms like fever, headache, those other constitutional symptoms do present. But reflecting wise, these are severe cutaneous and mucocutaneous, some of the severe cutaneous and mucocutaneous manifestations. So just to say, the presentations of abscesses, you can see from this one more clearer, and also the genital swelling I mentioned earlier on. And this case presents with extensive mucocutaneous involvement. Very severe, very troubling, and very challenging in our own context. And this is among people with HIV. Again, the anogenital manifestations, some of which I've mentioned earlier on, we are also very present. But detailed analysis of data among those that are hospitalized shows that 40% of them have genital involvement without involvement of the skin in other locations. So those are some unique presentations that our patients had. We are just emphasizing some of the presentations like tissue necrosis, as you can see on the picture on the right side, wherein this patient presented with extensive tissue necrosis requiring debridement when management is instituted. These are some of the features, some of them I've mentioned. But to look at special organs, such as the ear, such as the eye. So we also saw presentations from the ear, wherein there is extensive discharge as well as ulcerations in the inner ear as well as the external ear. So we saw all those manifestations among our populations. In terms of eye assessment, in fact, the reason why Dr. Jiba is absent, because she's presenting ocular manifestations in the American International Tropical Disease Conference in Canada. So there are lots of eye manifestations, and we routinely assess eye manifestations in those patients that do complain with pictures of eye diseases. So we've seen a case in which one person got blind, complete blindness. So for the complications, several of them, sepsis and shock associated with sepsis, severe anemia, several other complications. But one that is more challenging is what we refer to as mpox iris. We publish a correspondence in the Lancet that's we told our story using this particular correspondence, the challenges that we face when we start ARVs much earlier. You start antiretroviral therapy, the lesions worsen, systemic manifestations worsen, the patient deteriorates, and subsequently some of them died. So those are some issues that we got in the management of mpox cases. Of course, necrotizing fasciitis and gangrene, as earlier mentioned, we've seen one or two cases with urethral stricture, for which this was not present before mpox involvement in this particular individual. So those are some of the manifestations you see. The ocular features that I mentioned earlier on, ear involvement, and also we've seen cases with laryngeal involvement that present with dysphagia and several other manifestations of obstruction. Cases do present with encephalitis. We did not really do lumbar puncture to assess what is the status of the CSF in this population, but they do. And then several of the HIV opportunistic infections or HIV-associated opportunistic infections. We've seen cases of cryptococcal diseases and cryptococcal meningitis among those with mpox. Of course, tuberculosis, we've also been able to see in those cases. So several other manifestations present. But just to show some pictorial evidence of, in a more clearer way, of necrotizing fasciitis. And for this, we have been working with a urologist to help with some of this management in terms of debridement and also some form of rehabilitation. Got some advice from also a plaque with sodium. So these are all examples of necrotizing fasciitis, as you can see. So there are wasting manifestations that we are seeing. This case, we could not see clearly it's an HIV wasting syndrome, but really people come weight loss extensive, could be from HIV and just added with mpox. So this case did not fulfill the criteria for HIV wasting syndrome, but we felt there is an evidence of malnutrition, which also delayed tissue healing. So this is just the case. Now, generally to say, majority of our mpox cases, as you can see, the death are as a result of HIV. There are just few cases in which death occur in those that are not living with HIV. We've gotten a situation in which death occur in someone with poorly controlled diabetes. And for few, we don't know the cause of death, but majority, HIV is a driver of the cause of death. The population itself is fairly young among those that died, of the 60 cases so far recorded. And their mean age is 32 years. But they have advanced HIV disease. As you can see, the mean CD4 cell count for this population, for those that have quantitative CD4 cell count assessment, is 55. So telling us there is an issue. One of the critical issues that we faced, in addition to the mpox virus, which we described extensively in the Lancet Infectious Diseases, is antimicrobial resistance in this population. And whether this clearly indicates that there is healthcare associated infection in this context or not, but there is that possibility. As you can see from this pictorial evidence, we can see resistance pattern to most first line as well as second line antibiotics. So we can see that there are just few, like even among the carbapenems, it's ertapenem that is sensitive to this pathogen, which is Escherichia coli. But coupled with this is a problem around antimicrobial use in this population, for which before we put measures in place, many people were using antibiotics. In fact, there was a time we did a rapid assessment of this and realized that 80 to 90% of those people that do not have bacterial superinfection complication do present and use antibiotics, even at our own facilities where these cases are managed. Put measures in place to address that. Our management focuses in this population, supportive care, and of course, optimize antiviral therapy, for which we had challenges as well at some point, and management of opportunistic infections, such as TB, in others like cryptococcal meningitis or cryptococcal diseases. For advanced disease generally, we are doing a small project that we are assessing the persistence of the virus, but also correlated to the level of the CD4 cell count, and do urinary TB lab, which is used to assess TB in people that are very sick, might not produce sputum significantly. So our new intervention after the meeting WHO organized in Kenya, Dr. Jiba had a discussion with a dermatologist that says papaya from pawpaw has very significant impact on these people that have necrosis. So we have been using it. These are native ones. But just to give some scenario in this case, you can see we grind the leaves, and then we grind the raw pawpaw, the fruit itself, sorry, and then we use it. Now, this patient has this extensive necrosis, as you can see from the pictures at the top. But when we apply it at the surface and apply it wherever we have access with the skin itself, we saw improvement. So we see how these patients actually improve with the use of papaya. So this raw pawpaw, the young one, is the one that we grind to do this. Truly, there are some challenges with this because addressing the issue of potential infection that is there, but we saw that it improves the lesions in terms of the cure and improves patient outcome. Now, this is also another one. This man came from another country and then with mpox in one of the neighboring countries. So we have been managing this man with the raw fruit pawpaw, grinded one. And then we are having improvement in terms of, the necrosis itself. Necrotic lesions sometimes can just fall off and leave out the normal skin without even doing debridement. Because initially we bank on doing debridement. You debride, after 3 days, the same tissues again emanates necrotic tissues. So one of the issues that we have been pushing before is that you can see this man, his situation is extremely pathetic. This is how things have evolved. His genitalia, as you can see, up to this point, he's actually getting better. This is one of the reasons we are pushing for plastic surgery services in these cases, since locally we've not been able to be robust in addressing. So these are some of the unique cases that we do have, because potentially the way it is now, the scrotum is hanging, is exposed. The penile shaft is in this particular state, very challenging. So we've seen complications such as visual loss. We have seen this in one patient who recovered and come back. Now we are collecting specimen in those populations to see the persistence of the virus. We are working with the University of Nebraska in the US on this. So we collected a lot of specimen. Because part of the result is what Dr. Jiba went to present in one of the conference. We have what we call after the end. After mpox, there are a lot of challenges that are coming with our patients, such as contractures, hyperpigmentation, and urological complications. As mentioned earlier on with strictures, that we are not certain as to whether these are old strictures, but the manifestations occurred after mpox. So this is the case that had the visual loss. She has been assessed by the ophthalmologist. Some plans are being made in this context. So one of the things we learned during the mpox is that there has to be a call to action. And the call to action is to integrate services. So what we do is a dual integration of services. And that dual integration looks at both facility and community-led approaches. Several interventions were integrated. For example, for every case of mpox, although it did not start at inception, but for every case of mpox, we test using syphilis, HIV syphilis do. Although syphilis, the data that we have shows that there is no case of syphilis. And we did this because of the similar presentation of mpox to primary and secondary syphilis. So that's the content of it. And we provided management, screen for opportunistic infection. But also, we do demand creation and risk communication. Those are all interventions that we do apply to reach key population, provide vaccination. Well, we instituted vaccines in HIV clinics. Yes, at the start. And you can see we have so far administered 174,799 doses, of which those ones, 13% were administered among populations we refer to as high risk. The 90% to 93% of this number is for people living with HIV. So that's a dual integration. But we also bring in surveillance. into HIV services, and now want to move forward by conducting vaccine hesitancy among populations that are not vaccinated, understanding uptake of vaccines among this population, but also conduct an exploratory, this in the form of exploratory assessment. So we understand why you are not taking the vaccine. Address your fear, encourage you to take the vaccine. But during the process, we also ask for lesions related to mpox. So we are working with an NGO called Soltis in this particular project. So routine services are integrated, as mentioned earlier on. All these services have been mentioned. The aspect of integration, mpox surveillance integrated into HIV services, of course, development of a package of services for complicated mpox cases. So in conclusion, I'm fine to leave you by saying that mpox in the context of Sierra Leone presents uniquely. And there is a high prevalence of HIV among mpox. And we saw that the dual integration of mpox HIV services was feasible, and we made a significant progress in this context, even though we are not 100%, especially in the context of data. We are moving forward with some analysis as well as communications related to this arrangement. Thank you. Thank you. This is our flag, the green, white, and blue. It's a pleasure that I'm here representing Dr. Jiba. Thank you. Over.
Thank you. Thank you very much, Dr. Lako, and a big appreciation. And the sole reason why we called on Sierra Leone and we called on you and Dr. Jiba to come and present some of the data. We've seen significant HIV dominance in the mpox mortality from the Sierra Leone team, and good also to hear the after the end. What follows and what are we going to look at. And I also acknowledge and really appreciate the issues around integration of services. And I think this is the message that we want to really present to the participants today. So before we go into the next presentation, I would want IT to give us another poll question before Dr. Sebastian comes in with the WHO recommendation. Over to you, IT. Okay, so we just want to see really what are we practicing, what are we looking at. So WHO recommends rapid initiation of ART within 7 days of HIV diagnosis in ART naive patients, including same-day initiation for patients co-infected with mpox and HIV. Please just go ahead and choose whether this statement is true or false. And we'll give you about a minute or so to just see how this will come up. And as we do that, as we give you a minute, let me just ask also IT to share Dr. Seb's presentation before he comes in. Dr. Leko, you can bring down the slides so that we allow IT to. Thank you. Okay, so IT, maybe just try to see if you can share the presentation for Dr. Seb. And as we continue monitoring the polls from the participants. Great. All right, I think we've had some time to reflect on the polls. I would, at this point, okay, so majority of patients think this is true, and I think a proportion also thinks this is false, and it would be really good to hear what it will turn out after the presentation from Seb, and I hope this will spark some of the discussions that we are going to have after the presentation. And I'm happy to have Dr. Peters on the panelist as well to just give us the perspective from the HIV program. And it will really be good for us to interact really, because we've seen how dominant this HIV co-infection with mpox has affected some of the presentation and some of the mortality data. So at this point in time, please allow me to bring in Dr. Sebastian to give us the WHO recommendations around HIV and mpox co-infection. Over to you, Dr. Seb.
Thank you very much, Dr. John. Good to be here. So we've seen the polls, and it's time for us to look through recommendations of WHO for the management of mpox HIV co-infection. So next slide, the outline will be to even find out what's about the guideline. Why is it necessary to treat patients using guideline? What are the important aspects of guideline treatment in mpox generally, and especially in mpox and HIV settings? Then, of course, we want to look through infection prevention and control. We also want to look at some basis for guideline considerations, look at benefits and harm, certainty of evidences, values and preferences, resources, and other consideration. I would just want to reiterate again that we know that patients with HIV and mpox have higher mortality. From what we've seen, they have more extensive lesions. From what we've also seen, we also find out that there are also longer duration from publications and some particular presentation, morphological presentation, and there are needs for specific aspects of care. And so all of this, the WHO put together using standardized basis for evidence generation and appropriate walkthrough from evidence to recommendation. And so the next slide will take us to what especially do we need to do in patients with HIV. What's WHO recommendation in people with symptoms of mpox? What exactly has WHO recommended? And in the guideline, there's a strong recommendation, especially on the basis of moderate certainty of evidence. And WHO recommends rapid initiation of antiretroviral therapy in people with mpox and HIV and who are therapy naive or have had a prolonged interruption of the therapy. It's also important to highlight a few steps so that we also know that early HIV testing needs to be conducted. And so that brings to fore again the fact that I think that this encourages centers to ensure that for patients with mpox, particularly those with risk factors or even based on available evidences, screening for HIV is encouraged. And where facilities for treatment for HIV is not available, immediate referral should be done. And for the baseline is that viral load particularly is expected to be done. And if the patient hasn't had that in the last 1 year, we need to also have that done. And so when we look at this, we also must understand the fact that the treatment for mpox, either supportive or the established recommended treatment for mpox combined with HIV would have their effects. The last presenter talked about iris and other complications. And so when managing patients with mpox, all rules in care of management apply. So in the next slide, we want to see what we should do. Patient coming into our facility, we suspect mpox. How do we first attend to this patient? Infection prevention and control is of essence. And we do know, of course, that patients with HIV and other patients at high risk are advised be managed within the hospital facility. And so while we apply the general rules, hand hygiene, 5 moments of hand hygiene, while we also want to employ droplet precautions, safe injection disposal, appropriate environmental cleaning, in the event that we have suspected patients, WHO advises that they are managed separately. But when you have more patients, there is the aspect for cohorting in patient management. And that brings to fore again that the room where these patients are managed should have appropriate ventilation, and there are measures to prevent droplet transmission, especially when procedures that generate aerosols are put to play. Typically 1 meter distance between two cohorted patients needs to be put to use. Then special care needs to be given, especially to looking at care of the lesions. WHO has classified skin lesion burden into mild, moderate, moderately severe, and severe based on 0 to 25, 25 to 99, 100 to 250, 250 and above. So once we look at this, then of course, the particular presentation, patient with necrotizing fasciitis, there definitely will be need to ensure more aggressive treatment. And for this patient with mpox, there's a need to also employ a multi-special, disciplinary management, multi-specialist treatment, dermatology, infectious disease, plastic surgeons, particularly when you have deep tissue infections, have necrotizing fasciitis, extensive lesions. Then you also want to ensure that appropriate care is put to play when you are changing bed linen, because that's also another risk, that risk for transmission. Appropriate waste management, appropriate waste segregation. And so if we do all of this, more of the general treatment, we want to go at the next slide to look at resources and other considerations. So at the next slide, even in the management, WHO, in the guideline, WHO also give preference to looking at the resources and possible considerations in the settings where patients are managed, looking at equity of care, equity of treatment, acceptability, feasibility, justification. While it may be we may be put down as a rule that, as a guideline, that this is what is expected, we need to also factor in all of these areas. So these are the factors WHO put into all of the evidence gathering, evidence analysis to recommendation. And so let's look again at the WHO guideline for infection prevention and control in this next slide. So infection prevention and control guideline, this has been put as a conditional recommendation due to low certainty of evidence. Next slide, please. Due to low certainty of evidence as published in the guideline. And so we'll see here that in patients with suspected or confirmed mpox, WHO suggests that health and care workers use contact and droplet precautions, as I earlier mentioned. There's a need to consider the use of respirator when ventilation is poor or unknown, or based upon the risk assessment to assess the patients. In this regard, now we're looking at HIV patients, airborne precaution, especially if varicella zoster virus or measles are suspected. We do know that looking at the transmission dynamics, that appears more common in those regards. So that has to be more implemented. Of course, in aerosol generating procedure, there's a need to use appropriate PPEs. I've mentioned these single rooms. If single rooms are not available and limited supply, cohorted, confirmed patient care can be put in place. We'll look then in this next slide, why these patients are being managed. Because again, next slide, we also want to consider, WHO considers the psychosocial support, psychosocial aspect in the management of mpox patients. And so WHO also looked at visitors to isolated mpox patients. And then WHO recommends that for patients isolated with mpox, measures should be put in place to ensure adequate visiting and educate visitors and caregivers to ensure hand hygiene is done. They are supervised on how the instructions on how to wear their PPEs. then vulnerable patients like patients with mpox and HIV should be counseled regarding the risk involved, especially in informed decision making on whether to visit the patient or not, within the setting of whoever is coming to visit. The healthcare workers have assessed, and we seem like, oh, this patient, based on risk assessment, is vulnerable. The advice needs to be placed on the table. And of course, alternative modes of communication among family members and relations with video conferencing, text messaging, and all of that can always be advised in this patient. Next slide. Now we want to look at therapies. While we know that, yes, there are recommended therapies for mpox, we also do know within the things of mpox and HIV, WHO has advocated, especially for ART commencement. So in this next slide, please. In this next slide, we would see what the WHO recommendation is. And I also followed the poll. So we'll see whether or not majority has followed the WHO guideline. Next slide. So we'll see that WHO advocates that ART be commenced within 7 days of HIV diagnosis. If possible, same day to start HIV is recommended. Of course, all of these decisions are also within the precinct of the clinician's assessment on all the determinants surrounding commencement of antiretroviral drugs. We also understand, and WHO has put this forward in terms of the impact, that commencement of ART initiation versus not delayed commencement. It's been found out that, yes, mortality, ART, antiretroviral initiation, retention and reduction in viral load at 12 months apparently has better results when you commence ART early. Hospitalization, there are better results with that. Mortality is reduced. Then also retention and reduction in viral load are being found to be better within 12 months when this is done within the first 7 days or as soon as possible, even at the start of the diagnosis. Concerns were raised by the GDG group, and they well understood the concern of iris in patients when patients are commenced. So there was the recommendation that while it is advised that ART be started, it can be delayed in patients who have HIV and TB or cryptococcal meningitis. I looked through the reports from Sierra Leone and I found some cases of TB and all of that. So if the clinician managing assesses and feels that, oh, this is what the patient has, yes, there may be a room for a delay. Also, we look at early versus delayed initiation. As I've mentioned, reduced mortality. It's also noted that lack of evidence-based mpox therapy, risk of opportunistic infection, viral replication, and viral replication amongst sorry, could you go back to the previous slide, please? Okay, so this just summarizes what I previously mentioned. So next slide. So looking at benefit versus harm, because the GDG also looked at benefit versus harm in commencement of ART, the immune recovery, which is important in care and recovery of patients with HIV. It was found that this was better with commencement of antiretroviral therapy. And with risk assessment for iris, not too many studies have shown relatively high iris. And so based on this, coupled with clinician-based assessment, ART commencement earlier on is better advised. I also mentioned that all of these recommendations came on the basis of certainty of evidence. And so what were the evidences that the GDC looked at to make this recommendation? 3 randomized controlled trials on about 7,418 patients. It was also noted that the indirectness of mortality benefits, that is, mpox patients not being involved in some of these studies. While the extent of the RCT could have pushed it higher up, the fact that the indirectness of mortality benefits came in, brought down the level of evidence to moderate certainty. Next slide. So we look at values preferences. The GDG looked at it, bearing all evidences, and found that there are no substantial variability expected, and that patients will prefer the benefits of early initiation than the risk of high risk, especially when presented with, oh, Mr. A, Mrs. B, we're considering starting you on ART while treatment has commenced on mpox. Looking at available evidences, the value and preferences tilted towards patient likelihood to still prefer ART commencement. The next slide, of course, we do know that resources, feasibility, acceptance are important. Then the need to piggyback on the already existing ART provisions was also emphasized, as well as the impact of initiation of ART therapy on the pedestal of justification. And this justification, like had previously been mentioned, brought about the final recommendation that has always been, I've always talked previously. Next slide. So in this process, it's important to also take us through what studies that were done, the PICO that the GDG used in all of these considerations for mortality, high mortality, low mortality, hospitalization of the patient, and comparing early initiation antiretroviral therapy with delayed initiation. We'll find out that on the outcome of high mortality, we'll be able to see delayed ART probably increases mortality in mpox patients, as inferred from comparison of delayed versus early ART treatment. Other considerations are seen in this slide. Next slide, please. So looking again at IRIS, the odds when we compare early treatment versus delayed commencement of ART. Next slide, please. It was found that it was uncertain about the effect of delayed ART commencement versus early initiation in mpox on the occurrence of IRIS. And so based on all of this, that guided transformation from evidence to recommendation. Next slide, I'll just briefly look at some little implementation concerns from the field. Like, we know that, yes, we'll need to follow guidelines, but we also know that patients with mpox and HIV, because of the extensive lesion, because of the combined morbidity and the risk of mortality, they will stay longer. A typical 2 weeks, 2 to 4 weeks by which it takes the lesion to clear might be extended in patients with HIV. Cost comes in, and this is very important in Africa, where more than 70% of care is still out of pocket. So how do we ensure guideline-based care in these settings? Of course, this has to do with rely on the expertise and the experiences of people managing in those settings, looking at these guidelines and how this can best help patients' care. In all that must be done has to be done using scientifically available evidences. Then we also know that there are concerns for follow-up. We have seen pictures, and these pictures, there are cutaneous sequelae in this patient, pigmentation, there are scars. I've seen pictures that likely would give atrophic scars that likely might even need grafting in the long run. After this patient is discharged, the need for quality of life assessment in this patient is also important, because the scar, the pigmentation in itself is also what may stigmatize them outside of the setting. So while there's a need to conduct more studies, randomized control trials, qualitative studies, in fact, ethnographic studies that can explore more these concerns, it is important to note that these guidelines for mpox HIV care suffices for care of patients across all parts of the world. And so on this note, I want to say thank you very much for this opportunity to share thoughts in this regard. Thank you.
Yes, thank you very much, Dr. Sebastian, and always a pleasure to have you. I mean, you've brought out a lot of pertinent issues, and really, I just want to personally thank you for dissecting through this, and it's really good to see exactly how we've moved. This is benefit versus harm, and we are juggling around which one we should follow between the early and the delayed. We've seen how the delayed initiation has led to increased mortality, increased hospitalization number of days, and we've also seen what are the caveats around the iris issues, and what could promote delayed initiation. And mostly, I think the last two slides have just been so solid. We really need to look at what are the financial implications to this, and also the message around integration is very, very clear. We need to integrate these patients to already existing ART provisional programs, and that's really just outmostly important. I think I like the way you've really unpackaged it, and it's good that this followed the experience sharing from Sierra Leone. So at this time, I'm really happy now that we've got a round package. We've got a pieces of the cake brought together. We've partaken from each side of the cake, from the experience side, from the WHO side, in terms of the recommendation, and I think we've got a very good roundup understanding of this topic. So at this time, I really want to open up the floor for questions, for discussions, and I've seen there are a lot of discussion points in the Q&A. But I also have a pleasure of having Dr. Peters from the HIV program. Maybe before I open up this discussion, and also just a few, let me hand over to him to just give us some insights to this, and then we can pick one or two questions that we can discuss, and maybe in his giving us the insights, maybe he can even try to answer some of the questions he has noticed in the Q&A. Over to you, Dr. Peters, and thank you so very much for being here.
Thank you, John, and thank you to the organizers for organizing this really timeless and relevant webinar. It's really great to hear from the colleagues on their experience and the lessons learned. And I think it's really important to hear these stories and to see these cases like Dr. Lacko did earlier, because it puts an image to what we are talking about. I think from my side, and I know I'm supposed to close later on as well, so I won't say everything yet. But I think it's really important to understand the importance of HIV co-infection. I think it was really shown very strongly earlier by John and by Dr. Lacko as well, that we see such an overrepresentation of people living with HIV in those who suffer the worst disease. What I haven't heard much about yet is the importance of early testing and early presentation. And we see a lot when we look at these severe cases, often it doesn't happen overnight. It's people who have either been to the system or have been at home for quite some time before they present to our health services. So a strong emphasis on creating a space where people can present early and actually can test early as possible, I think is very important to try and prevent some of these severe diseases from happening. So I think, in our settings, we should really think around accessibility of services and testing for both mpox and HIV, because the earlier we find it, the less likely people are to progress to these severe cases that we've seen. I think also the second thing I want to highlight, and it's really great and I actually saw the publication from Sierra Leone as well. It's really important to collect data, because we are in a space where there is evidence, but not a lot. Dr. Sepp also alluded to that we really need a stronger evidence base as much as we can. In particular around co-management and co-infections. And I saw one of the questions in the chat on Mycobacterium ulcerans. I think it's a very relevant question, but there's very little data out there. So I think a push on what do we actually see, what do we experience in the co-infection space is really, really important, and what are our outcomes. And I think the third point I want to make is people with advanced HIV disease, as most of you know, they're actually relatively sick and tend to present with multiple conditions. So it might not be mpox alone or severe mpox alone. It might be TB. It might be other conditions that come with it. And it makes it quite difficult when people progress to more severe disease or they die in the end to really understand what they died from and what's going on. So quite often it's important to look in these patients, not only for mpox, but also what other infections might be there and might need treatment. So it's a complex presentation, in particular advanced HIV disease, where we really need to look as broad as we can and provide comprehensive care. And I think the last comment, and I think Dr. Sepp also related to that, is it's a very thin line. So we see people deteriorate because the mpox virus replication progresses. And we have very little to stop this. And the one thing that can put mpox back in control is to restore immunity. And the way to do that is antiretrovirals. But we do know in some people, the mpox is outcompeting sort of the immune restoration, and in the end, people progress and might die. And it makes it quite difficult to understand whether you look at iris or whether you look at simply a progressive mpox infection that outcompetes the immune system. So a lot more work in that space as well, I think, would be really, really beneficial to try and understand what's happening in these patients and what can we come up with to offer to them. But with that, I think, John, I'm going to hand back to you.
Thank you very much. Thank you so much. And I think the points are really driven. And one of the things I think I would really pick up is the early testing, and also just provision of that access to laboratory confirmation, and also just linking the mpox testing to also the HIV testing, and then also looking at the data collection. And it's very key that we have the evidence. There's so much happening, but there's so much little or scanty data coming up. And one of the reasons why we brought up this was because of this scarcity of the data around. And then, of course, there will be some complex presentations of HIV, TB, mpox that really will just progress with or without some of these interventions coming through. But it's very important. So I've got 3 questions. I think that will go to Dr. Lako, and they are bordering around experience. And these are coming from Wilbur. So Dr. Lako, Wilbur wants to understand, is the mpox clade in Sierra Leone the same as the clade that is driving the infection in other countries? And on top of that, he also has the team checked for co-infection with mycobacteria in terms of those oscillations that you showed us? They're so extensive. Has there been anything done around that? And is there any study analyzing the immunology in the HIV mpox co-infected patients in Sierra Leone? Over to you, Dr. Lako, in a brief.
Okay, so thank you so much. In terms of whether a study has been conducted to assess immunologic markers in co-infected mpox HIV cases, that has not been the case, and we look forward to that. So there is possibility that there is that disruption. What we see over generally is that there is a rapid improvement when ART are initiated. As I said, we are following a small cohorts from the time they are diagnosed. So collect samples from the lesions to check for the persistence of the RNA virus. That is not an ideal way of doing it. We are not doing culture because we don't have that facility. But just to give us an idea when we should discontinue the care. So thereafter, we are also following up to look at subsequent CD4 cell count, and we saw that within maybe a month or two, some people may have up to 50% increase in CD4 cell count. I think that's the only immunologic assessment that we are doing. We're not looking at any other immunologic assessment. In terms of mycobacteria, in the context of Mycobacterium ulcerans, which causes Buruli ulcer, our skin NTD program has not been very robust. It's now that we are starting with an assessment of Buruli ulcer. But in 2006, there's an assessment conducted here that shows that we do have Buruli ulcer in the context, but that was not considered here in this particular assessment. For Mycobacterium tuberculosis, of course, we follow the HIV guidance, and using the HIV guidance, we are able to make sure that we do screening for everybody that is tested positive for HIV. And then we do screening using urinary TB for advanced diseases, followed by gene expert assessment. So for those who are not in the category of advanced HIV disease, so we do sputum expert most often. I can't remember the first question. There is one question that he asked first. The first one.
The clade of the...
Okay, so for the clade, we have clade 2B in Sierra Leone, which is different probably from the experience we had with our colleagues in DRC. They have clade 1A, but we have 2B in our own context. It's supposed to be mild. It's supposed to be less aggressive compared to from the theory we had previously compared to the clade in Central Africa and in other locations. But here now, what we are seeing from the data even presented today, you can see that we have a high case fatality rate compared to what happens elsewhere. Maybe this is driven by HIV itself. So it remains to be studied because there is a flip of the historical prognosis of mpox between clade 1 and between clade 1A and clade 2B. Thank you.
Thank you very much. Let me hand over to Dr. Rashidatu.
All right, thank you. Thank you very much for those brilliant presentations. You all would agree with me that we have definitely had some insight into what's happening in the countries. And also to Dr. Seb, excellent presentations on WHO's recommendation. So the next set of questions will be directed at Dr. Seb, and they are around WHO's guidelines. And I think one of them would be taken by either Prof. Yap or anyone representing Africa CDC. So let me just read out the questions. So it says, given the context, how many patients were sampled to arrive at the conclusion that they prefer early ART vis-a-vis risk of IS? Furthermore, how much information was given to patients to inform their decisions? This one is for you, Dr. Seb. And then the second one is the impact of current regimens for ART different in terms of mpox prognosis and outcomes? And the one that I would like my Africa CDC colleague to respond to is, given the context of papaya treatment in Sierra Leone, how far is Africa CDC gone with launching natural therapeutics clinical trials for mpox in Africa? So we'll start with Dr. Seb, and after which we'll have Professor Yap to respond. Over to you. Thanks.
Thank you very much for that. Like I mentioned in the presentation, there were a couple of studies that were looked at. There was a combination of observational studies and 3 randomized control trials. There was a study that was considered about 7,000 patients. Then another looked at about 2,000 patients thereabout. However, in the decision to as to ART versus in the setting of IRIS, it was found that in the comparator group, using the PICO now, that there were a lot more. There were about 100 per 1,000 patients compared to 112 per 1,000 patients when it had to do with IRIS presentation in delayed versus initiated ART setting. And based on that, the decision came to the fact that, yes, it was uncertain that the effect of delayed ART initiation, it was uncertain that the effect of delayed versus early ART initiation in mpox on the occurrence of IRIS was of importance. So this also adds to the reduced number of studies that considered IRIS in the setting of mpox HIV patients. So summarily, there's a need for us to gather more robust study in this area and strengthen further recommendation in future guidelines for mpox, HIV, and IRIS. I hope I've been able to provide some answers to the question. Thank you.
Excellent. Thank you very much. So can we move on to Prof. Yap or anyone who is sitting in for Africa CDC? Let me just read again the question. Given the context of papaya treatment in Sierra Leone, how far is Africa CDC gone with launching natural therapeutics clinical trials for mpox in Africa?
I've seen Prof is not on the call anymore. I think he has dropped off. Patrick should be having some internet challenges, but I think it's something that we can follow up with the team in Africa CDC and try to see what the landscape around that has been. Okay.
Yeah, sure. Okay, then, so back to you and Dr. Masina.
Okay, thank you so much, Dr. Rashidatu. And I think I just want to highlight one thing, and we're running out of time. I want to highlight one comment from Anya Onkoro. I think she highlighted a few issues around psychosocial aspects of the management of mpox and HIV co-infection, and I think this is also very important. We might be tempted to tip over to clinical management and management of these lesions and management of the of all the things that we can see, but there is also a strong connotation on the psychosocial effect of this co-infection of HIV and mpox, and just the fact that there is CNS involvement also worsens the psychiatric complications, and I think this is a very important point. we tend mostly to leverage on the clinical management and the physical management of all these diseases, but we somehow underlook the psychosocial aspect and the psychiatric complications, and I thought that is really an important comment to highlight. So we are running out of time, and I want to really thank everyone. And let me give an opportunity back to Dr. Peters to give us the closing remarks. And over to you, Dr. Peters. Thank you.
Thank you, John, and thank you to the entire team and speakers for putting together this incredibly useful and relevant webinar. And we started off with Prof. Jap saying that we should really learn from each other and collaborate. And I think this was an amazing learning opportunity where we heard two very strong stories showing one experience in the field with the management of mpox and all its consequences. And on the other hand, we heard the guideline in management story, which I also thought provided a very nice overview of where to go. And both speakers highlighting the importance of comprehensive primary care and looking beyond HIV and mpox only, whether it's about comorbidity, whether it's about infection prevention control, or whether it's about psychosocial support. So I really hope that that this provides the opportunity to continue conversations between the experts, between the institutions, and for those of you working in the field. And let's continue to collaborate and make sure we get the best outcomes for our people. So thank you very much, and happy to hand back to you, John.
Thank you very much, Dr. Peter. And I mean, it's always a pleasure to collaborate. It's always another point to learn and a lot of learning. I think the points that have been highlighted really valid, and there's a lot that we can share. So I just want to confirm with everyone, we are going to share the slides with just permission from Dr. Lako, if we can maybe blind some of the photos, or maybe if we can share, but we'll try to see what best will be shared, and we're going to share them in PDF with everyone who registered for the webinar. And really looking forward to having you again in another webinar that we are going to announce. For now, thank you so very much. Have a good evening, and enjoy the weekend to follow. Thank you so much, and we can end here. Thank you.